Good afternoon. I'm Kirk Heath. I'm the CEO and founder of Modio Health. Yul and Mike Lee, thanks for inviting me today, and my new InTouch friends from Argentina. Thank you for the hospitality yesterday. It's great to meet you guys. So I first ran into InTouch Health literally when I was a surgery resident, and the rounding robot came around about 10, 12 years ago at Norfolk General with Mike Fabrizio's face on it. You could hear the robot coming around the corner. You could also hear him singing on the robot. So that was my first interaction with you guys. It's great to come full circle. What's also great to see is the technological advancements in healthcare and just in general. I've been tasked for my kids to find a Pokemon out here somewhere in California and bring him back to Virginia. Unfortunately, I can't figure out how to get him into the phone, so you guys may need to help me. I've only got about 10 hours to do it. But in all seriousness, the technology in healthcare is truly amazing, whether it's EMR, whether you believe in it or not, whether it's robotics or rev cycle technology. It's great to see really where we've been going. It's truly great to see. The one area, that it really hasn't gone anywhere in the history of its existence is credentialing. And I'm going to get away from science now. We're going to talk about processes. So imagine a surgeon talking about processes. So here we go. So a healthcare provider is one of the most difficult professional positions to credential and keep compliant. For both the credentialing team and the provider. The providers whine about it more, but the credentialing team really bears the burden of it. And I am one of those providers that used to whine about it. And I'm going to teach you a little bit, and I'm going to teach you some of the providers here on why we credential and why we credential folks. It's not just filling out an application and having privileges. But for every single facility that I have to practice in, I need an application, copies of my diploma, I need a license copy, all my CME. And then not only do I have to give it to them, someone in that hospital, or they've contracted out to someone, has to go verify that. And it's done manually. They pick up the phone and they log in to the Virginia Medical Board or California Medical Board. They do it manually, and they still do it this way. It's absolutely absurd that in 2016 we're doing it this way. So this is a real picture on our conference table back home, and this is a credentialing application from one of the healthcare organizations that's in this audience, and I won't out you because you're a great client of ours, but that's the application. How ludicrous is that? For one provider in one hospital in our area. But what that leads to is application time. It takes about 10 hours of physical labor to fill out that application, gather the information, and that's not the time they get credentialed, that's the labor to complete all the steps in that application. State licensure takes about an hour, DEA takes about 30 minutes, CAQH, if you know what that is, 1 to 2 hours. And then re-credentialing, less time, obviously. But if you look at the average credentialing time for a provider across the country, it's 90 to 120 days for me to get credentialed in a hospital. Absolutely absurd. I have to show this one. It's the same organization. I just filled this out about a month ago. This is a signature page for me. There's a typed with a typewriter name. I signed my legal signature. I then signed how it would appear on my medical records. I initialed that, and then I initialed the bottom of the page to say that I'd initialed it and signed it twice. So that's just ludicrous. And notice this is on paper. I can't even get you an electronic copy of this. This was on paper, and it came to me via a fax machine, which came electronically. Absolutely absurd. So here's the problem, and this is if you look at a provider's environment, and this would be mine. So I'm the provider at the bottom. I've got the 3 hospitals I operate at the top, ambulatory surgery center, I got my practice, payers, and licensing boards. And whenever anyone needs something, it's chaos. It's, hey, let's send the provider to it, let's go to Board of Medicine, hey, can you send me the COI, the Certificate of Insurance, the CMEs, and it's ludicrous, it goes around and around. So telemedicine, you thought that was bad. So telemedicine, if you have to go credential providers in 50 hospitals and across 10 state lines with 5 DEA licenses, because you can't just have one DEA license for a federal license, it's actually a registration, a federal registration. I've got to have one for every state I operate in, and that's because it's $700 and it goes back to the DEA, and I think that's why they do it, but I didn't say that. But anyway, so it's an exponential problem in telemedicine, so, and that's what we're going to try to tackle today. The result in this is cost and time to credentialing, and that's a big problem because it puts the processes at risk. You have practice delays, inability to write scripts, inability to take care of patients, and inability really to deliver care. And for telemedicine as a provider, that has got to be a deterrent. It's bad enough I got to fill out all the applications and do that for 1 or 2 hospitals, but if I have to work with the credentialers to do 50, 75 hospitals, that's nuts. I may decide to not do it. So what I call this is out of sync with the growth of the rest of the industry. Credentialing and privileging is out of sync with the rest of the industry. So really it's a growth mismatch. And because credentialing is really inherently tied to so many processes and sectors in healthcare, it's imperative that the growth of the credentialing solutions matches the growth of all the cool things I've heard the last 2 days and all the other industries, all the sectors of healthcare, or we're just going to have these great big bottlenecks as we move through. So I'm not, credentialing is needed, and I don't want to take the position of a provider who just complains about everything, then I go back to the OR lounge and let someone else deal with it. We're going to provide a solution, and that's what we've tried to do. The characteristics of a solution that I would propose, which you're going to see here in a minute, it's got to be dynamic. It's got to respond to the industry growth and the changes. It's got to be cloud-based and mobile. When I get a peer reference request, I don't know if any of you are familiar with that, but it goes to a provider, and 3 weeks, if you're lucky, it comes back because it went to my email, and I'm only going to fill it out if that provider comes to me or I get 5 more emails. Why can't I just get a text alert on my phone with DocuSign and fill all this stuff out and sign it, and it's back off? And that's what we've done, and it's a great way to kind of speed up the process. Also, let's empower those providers to help with that credentialing. Let's embed it in an EMR. Let's embed it in, Epic, Cerner, or any of these EMRs where they go do all their medical records and charting, and we just shoot one little task in for credentialing so that they don't have to fill it out, wait for emails, and use that dreaded fax machine, which none of us have anymore. So what does this look like? Really, it's got to be automated. It's got to, so all the data we wanted to pull, a lot of this stuff is public data, and I shouldn't have to type in my NPI number and then type it in the Virginia Board of Medicine and then type it into the California Board of Medicine. We should all have that, and it should be pushed automatically. So what we've done is we've taken this chaos and we've created this. Why don't we have a centralized database? Now, I want to make an analogy here. Patient records 10 years ago, I would have my record at my primary doctor's office. If I had surgery, it'd be at the ASC. If I went to another hospital, another doctor, it would be all over. So somebody came up with it and said, let's put all the patient records in one centralized source. Why don't we do that for providers? And that's a great idea, and some folks have done that. Most of those solutions are just look at one organization. They don't look out at the provider, and it's internal, and it's a static database. Why don't we create something called, what we call OneView, which is a circle, the slides are coming out right, it's a circle where all the organizations can access shared data with certain privacy settings, and the providers can access it as well. If you go look for another job, either a locums or perm job, all of that data can be available to the recruiters as well. So that's really cool, and you'd say, oh yeah, that's pretty neat, but the really cool thing is we're gonna pull this information from regulatory agencies, licensing boards, payers, anywhere we can get it. We're not gonna go buy a database, we're gonna get it from the primary source, as it's called. So why don't we take this picture I showed you before and turn it into this? It's still it's not as complex and as chaotic, it's organized, but now I can have all those hospitals that the telemedicine providers are credentialed at, accessing that information and doing it in a timelier manner. And then all of the agency data is going to be pulled into OneView. And again, the provider can access the data. So I put this slide up there because you had it last night, just the whole networking. Why don't we use what Sun Microsystems did, use the network and use our skills and our technology to make this an easier process. So it's a cloud-based system, real-time platform, no on-site updates, no static servers. We're going to pull your NPI, your DEA, your license numbers, your work history if we can. And we're also going to store documents. I can shoot out tasks to the providers if I want to, and hey, Dr. Heath, go get your PPD done or anything I need, and really keep a real-time update of what's going on. I won't get into recruiting, but imagine when I have thousands and thousands of doctors on my platform and I have information on them and they've said, hey, we want to go work for somewhere, or we want to work somewhere, we have those doctors available, particularly around telemedicine. We can help deliver that care quicker if we can get them credentialed quicker. So we also have the provider-facing platform as well, and you can notice, I call it bait. We bring the providers in. Providers can always come in for free. They come in and get their CME opportunities, et cetera. But it's allowing them to participate in the care, or participate in the credentialing so that they can deliver care. So just finishing up here, we've taken the time, and these are real numbers, and it's the same institution that I was picking on before. We've taken, when we put our providers into that institution on a locum or on-demand, we like to call it on-demand, it's sexier than locums. We've taken that hospital application time down to 2 hours, literally 2 hours. State licensure down to 30 minutes, DEA down to 20 minutes. CAQH, I can't help you yet. They're not letting us have an API into their technology. And then re-credentialing is considerably quicker. And what this means, that 90 to 120 day credentialing time, the time that it takes, the time when they say, yeah, you can practice, we want you to practice at our hospital, to when I can, we've taken it down literally to 30 to 40 days. And it's a huge, huge reduction. And what that leads to is, with a decreased time to credential, you can deliver care quicker. If we're having this physician shortage and we're going to use telemedicine to deliver the care, I'd like to get it two months quicker than I normally could. If you're on the revenue podium, I can also start billing 2 months quicker, which is great. Compliance risk reduction is definitely a factor. We can see these alerts coming out when licensures expire, and it's a very proactive system. We reduce the administrative burden, and we decrease the cost. So I'll finish with this. So credentialing is definitely not a sexy topic. Most providers will walk out, they'll start throwing things at me, but I will tell you, neither was taking a cab ride until a few years ago. So thank you very much. Yeah.